attendees. This is in addition to the panelists. So I think we have a good number enough to start. All right, so I'll start by introducing myself. My name is Ajia Kiring, and I work for the TBPPM Learning Network. You're all very, very welcome this afternoon to listen to this webinar where we'll be discussing strategies around capacity building for private providers of TB services in Nigeria. I'll give you a little bit of a background on what the TBPPM Learning Network is before we jump in. So the TBPPM Learning Network is a network which is global, but at the same time, we have a Nigeria chapter. And our goal is to create a robust community of practice where we discuss and share learning around PPM within Nigeria and globally as well. So that as we implement, we're also making sure that we're learning and that we're recording and documenting that which we are learning, ensuring that whatever one person is experiencing and whatever one facet of the program is experiencing, others are also learning from it. We're learning best practices. We are deliberating on some of the challenges that we're experiencing, and we're having a robust discussion about it, hopefully to improve implementation as a whole for everyone. So that is the overall goal. And the topics we choose are usually chosen within the scope of the stakeholders. So most of you here have shared your opinions about some of the things that we should be talking about, some of the challenges that we experience as a group. And this is why we're talking about this topic now. So that is it in a nutshell. If you are not already a member of the TBPPM Learning Network, we encourage you to join because there's a lot of learnings that is possible on the network. So we have a website, we put up different kinds of information that is relevant to PPM and learning in that sector. And it also is an opportunity for people who are working in this space to also showcase the work that they're doing. So we will put up the website. So please sign in if you are not already one. And if you're already one, we encourage you to also have a robust discussion with us on an ongoing basis. So I will, at this point, hand over to Stella. Stella will give us, will sort of give us a bit of an introduction into what we're talking about. We are supposed to actually have the national coordinator give a goodwill message, but he's busy right now and he has promised that he will join us at some point during the course of our webinar. And whenever he joins us, he can now give the goodwill message. But for now, I'll hand over to the PPM focal person of the National TB Program, Stella Marco. Please, please go ahead, Stella.
Yeah, thank you, everyone. So this is Stella Mapu. So I'll first start by introducing the webinar topic. The webinar is on strategies for sustainable capacity building for private providers of TB services in Nigeria. This topic was chosen because, over time we've been experiencing staff attrition in the private sector. You build their capacity today, tomorrow if you go there, they are no more there. So we've been thinking, what do we do? How do we overcome this problem of staff attrition? So that is why this topic has been on the front burner for a very long time. And we are X-raying it today so that we'll be able to see if we can get sustainable solutions to the problem of constantly building the capacity of the health workers in the private facilities. So because of this problem of staff attrition, we will not close our eyes to the fact that we need to the fact that we have to ensure that the quality of TB services that is provided in that sector is standard. So that is why we are coming up with this. Encourage active participation. Please let us feel free to share our insights, our knowledge and questions. So The first speaker I'll be introducing this afternoon will be our data queen, always data-driven, Dr. Obioma Chijoke Akaniru. She is the M&E manager for NTBLCP. So she will set the ball rolling. She will give us the background, and she will share how the program builds private provider capacity and the successes and challenges encountered. From there, we will go to Dr. Adetiba, who will also share the IHVN experiences. Then we'll move on to Dr. Sheshi, who is coming from KNCV. So he's going to share his experiences on a TB Loan 1 and 2 project. And lastly, we'll hear directly from the experienced private providers who will share their personal experiences. The first will be Aliu Usman from Al Shifa Clinic and Medical Services, Sokoto. We'll also hear from Emmanuel Onyeje from L Laboratory Diagnostic Center. We had to make sure we invited someone from the clinical aspect and from the diagnostic aspect, so that we'll be able to appreciate these experiences we are having. Details, you can get their full details from the TBPPM Learning Network website. So we'll still open the questions, comments. Then also, we will urge us all to feel free to ask questions and comments in the chat and put up our comments in the chat. Challenge, because that's the topic that Dr. Obioma is going to take us on. Unique challenges of capacity building for private providers rendering TB services. So what do we mean by unique challenges? These are not necessarily challenges that have never been seen before. I'm sure that most of us involved in implementation of PPM have come across, and of course, not just PPM, also public sector as well. They have come across similar problems. However, given the private sector context, how are these challenges manifested in that context? How does it impact service delivery, and what are the potential solutions to some of these challenges? So right now, I'm going to hand over to Dr. Obioma Akaniru to take us through the NTBLCP experience. Thank you very much. Dr. Obioma, are you there?
Yes, I'm here. Thank you, Stella. Okay. The host, you need to allow me to start my video, or you see if you can do it from there.
Sorry, Obioma, I don't think we are having that feature here on our end.
Okay, so it says here you can't start your video because the host has stopped it. So I think maybe there's something you need to do. Or rather, you start it from there.
We'll check in the back end, sure.
Okay. But I think you can start it from there yourself.
It appears we are not able to. So you can proceed with the presentation. And
okay, that's fine.
Try to figure it.
Okay, that's fine. Okay, good evening or good afternoon, everybody. And I want to thank PPM Learning Network for this opportunity, and also the national program. And I'm presenting on the unique challenges of capacity building for private providers rendering TB services. So it's going to be a short presentation because I kind of have summarized it in terms. So it's already known for the benefit of those who may just be joining us for the first time, Nigeria, as the most populous country, is also one of the countries that are stipulated as high burden for TB. And it's also good to mention that over the years, we've tried to improve in terms of our case finding. And part of the strategies we use is expansion of the DOTS sites. And based on the need to ensure that every facility or there's improvement in access to TB services, the national program has also adopted the fourth strategy of the Stop TB, which is to expand by engaging the private sector. Of course, we know that engaging the private sector has been a unique venture, which has required a lot more skill and tactics than we had with the public sector. Then, okay, thank you. So we've been able to expand to up to 22,000 health facilities, out of which 20% of them are private facilities. And we also, as we expand our DOTS facilities, also our experts, which is our primary diagnostic tool, or TrueNat, is also being expanded, and of which we have up to 90 private facilities housing these experts. And this is just to ensure that we improve or increase in terms of the access to diagnostics. Of course, we know that in some parts of the country, there are some parts where the only facilities that we have in a particular region is just the private facility, meaning that they are also key to improve access in the country. I won't bore you so much with the schemes of service, but just to mention that there are 4 types of scheme in which we enroll these facilities. There are some who just help us in identification and referral of the presumptive, and this has to do with one choice. Secondly, also based on we have a checklist which we utilize to ensure that a facility has the standard criteria to be able to house the scheme. So we have those who are just identify and refer. We also have those of them who would be able to go further to diagnose. We have those who can diagnose and treat and all that. So that makes it 4. Then the scheme number 4 is identification of presumptive TB diagnosis services and treatment of a diagnosed patient. These ones are the ones that further go on into case holding and ensuring that these patients are followed up till they are treated successfully. So we've made some achievements in the aspect of this PPM, and we've gradually increased the number of facilities expanded to. Before we started our unique PPM strategy that took off in 2019, we had less than 1,000 facilities providing these services for us. But between then and now, we've been able to expand to almost 4,000 facilities. Then for the steps of engagement, these steps are actually very important because they are the defined steps that every private facility that is being engaged would have to go through. And the first one is the assessment, like I told you. Then you identify the model which you want to establish in that facility, which is based on some criteria, which we may not go into. Then you now have to have a dialogue with the management or the owner of the facility to obtain consent, sign an MOU. This MOU would be able to elaborate the services you expect from them, what we need to provide. Of course, there are some logistic aspects that we need to provide, and also the monetary aspects, what would need to come from us, and also what they need to do would all be spelled out in the MOU. We have the aspect of capacity building now come up, which is the topic for today. So in terms of capacity building, of course, you would need the management to identify a staff who would be the key or the focal person to handle the aspect of TB services in that area. Then we play our part in terms of logistics, R&R tools, which are being handed over to the facility, but mostly to this focal person who will be handling this. Link them up to the public facility, which is the state and the local government for routine supervision, and also to ensure that most of the things they do is streamlined to the program. So what has worked for us in this approach? In fact, it has been amazing for this past few years in the program. And we've seen improved coverage or improved access, like I said before. And the fact that we've been able to expand in kind of fragmented pattern to different cadre of these private providers has also made it easy, because we know that the pattern in which, or the behavior for care seeking for different regions in Nigeria are also different. So in some parts of the country, you see a lot more of this cadre of private providers. In another part, you see another cadre, maybe the PPMVs, maybe the CPs, maybe the faith-based organizations. So it shows that each and every one of them is important depending on the area we are dealing with. And this has also helped us to improve access. Then it has helped us to ensure that quality medicines are being delivered to these patients, unlike before, when we ran one of the OR we did around FCT and Ibadan. We found out that the non-engaged private facilities were actually not implementing with the right regimen, and some of them are still placing on isoniazid for 6 months and believing that that's still what the treatment is. So that quality medicine and ensuring that the management is accordance to our guideline is one of the things that has improved. Then there's good oversight and use of our policy documents, and the HR and skills and capacity of these people have also been improved. So you will find out that most of the things happening are in line with what we do in the program. Then the aspect of having a linkage coordinator, which bridges the gap between the private and the public, has also been like a kind of a goal scored for the program, because we at initial, you just have the private sector as private providers engaged, and at the end, you start looking for things like the data, cleaning up of the data, and having even the patients who would prefer to be treated in the public will be lost on the way. In one of the OR we did, we tried to look at the number of private, the patients who start from the private and are referred to the public. And we found out that about 52% of them are referred to the public. And out of that 52%, we tried to trace, and we could only find about 9% of them who arrived at the public facility, meaning that a lot of them are lost and not even seen along that pathway. So this result just shows what we have so far in the program as the yield from the private facility. So going into capacity building for the private providers and what we do in the country. First of all, we try to organize based on the resources to make this training or this capacity building in facility. Of course, there are so many reasons why you have to make it in facilities. One in facility, because one is the availability of resources. Another one is also the availability of staff. Most times you find out that they have less staff and might not even be able to release a staff for you for the whole of 1 week or that. So you keep trying to make sure that you also pass this skill within the confines of where this particular person is working. So, but in organizing the training, we try to include as many people as possible, like the OPD doctors, the nurses, just to have a lot more hands learn about this. This actually helps also in transition in case if there is any attrition, to see if there's someone you can hold on to before they pinpoint someone else to take over this aspect. Then another aspect of the capacity building is because we have different cadres in the PPM, all modeled up and called PPM, private providers, we still know that there is distinction amongst them. And based on it, identification of each cadre and tailoring the training to each of these cadre is very important. Of course, you get to some of the private providers and you just have to do this training in their mother tongue, because whatever happens, whatever material you have prepared in a particular language, maybe the Central English language, would not help you at this particular time. So ensuring that the training material is brought down to the point where they can understand is another thing. And this is where resource persons are required, because the person who is about to who is coordinating this training and who exactly will handle this training, these are two parts. So there might need to be a step down to someone, or looking out for a resource person who would understand the training and also be able to pass this training in their mother tongue. Then you give more time to demonstration and repeat demonstration, because now you have things like the tools and the aspect of sputum collection of specimen and all that. You just have to give more time to it, especially when you're coming towards the lower cadre of the private providers. At this point, some of them, they're just getting to hear this for the first time, and you need to take time for them to be able to fill in the documents or the documentations that are required for this. Then in terms of this, the training material is also modified to fit their simulation level. So some of the training materials, you just have the tools. Some of the times you have to label the tools, like what you do exactly to the training material now depend on the people you have to train. So all these are the things that go in with the training before you finally release them. The private providers, the sensitivity of the private provider is that you have to be sure that this person understood you and would be able to carry out this particular task when left on their own. So there is also a lot of monitoring and peeping at the initial time when this particular facility or this private provider is brought on board to start discharging their duties. Then finally, the introduction to the linkage coordinator or the linkage mechanism is important, so that there's also oversight in what they do in terms of their data, the specimen, the patient management. And then you now onboard them with the seed stock of our R&R tools, then our medicines. And by that, we expect that the center is activated. There are some challenges we get to see. One that is always mentioned, which is attrition. Of course, the attrition, the way the private sector is, people easily come in and leave, and this is something you can't stop. Sometimes staff are redeployed from one point to another, and you can just train someone today and you come back the next day, come back for the next supervision, the person is no more there. And you just need to do something to ensure that this go on. So I really salute the people who work in the aspect of the PPM in the program. They actually have a lot of work. And if you have to do one work in the public, you may need to do 2 times it. That's the level of effort you have to put in the private sector to ensure that these things are moving. Then sometimes we might even have in the attrition, you can have a private provider, like maybe the PPMVs, CP, they can just close up their shop for a while. Some will say, oh, I need to go for planting season. Some of them will say, oh, I need to go for this celebration. And for that period, they are not answerable really to anybody. And you just find out that even though they are high burden and they are leaving, sometimes they leave and put a focal person who you may need to bring up. So all those things border around attrition, which has become a big issue for the program. Then another issue we have in that capacity building is what I've mentioned. The private providers, one nomenclature, yet very diverse, and you will still see that aspect of cadre play out within them, where a particular group feels that they are allies of the PPM, another group feel like they are too learned to be joined with other people. And you find it making it the whole process difficult, because you can't really bring them up under one umbrella and try to push a particular agenda. You just have to give that segregation to be able to rub the ego of different set of people. So it also makes the inputs into this aspect of the training a lot more tedious and requiring a lot more resources, because the training material would have to be diverse. You formulate each for each cadre. And also the resource persons for each of them would have to be. And of course, the training, you can't even put it all in one place if you want it to be on site. You still have to divide into this. It doesn't matter how many the numbers are because of the diversity that is found within them. Then also, we have the aspect of sometimes they give you a staff and the staff they give you will be multitasking. He's the one covering OPD and covering the gynae and covering somewhere else. So sometimes you find it that even though you are trying to put on board, you see that the trainings you're having as much as possible may not be as efficient because with time, there is kind of weighting of the knowledge and misapplication of some of the workflow. So you come back seeing that RR2s are not well filled and sometimes, so it gives you, you keep having like a vicious cycle of training with this, but you really can't blame this person because there is a profit-oriented organization, so they actually don't employ as much hands as possible, and a whole lot of things are tied around individual. So you also notice some things because of the multitasking, some aspects of this train which you expect them to onboard, like contact tracing, would also be lagging because the staff actually doesn't have enough time to spare to follow up the other aspect of the program pathway. And sometimes you see that the training is not even as efficient for you because you keep truncating, especially if it's in facility, you keep truncating as if the attention of this staff is required in different places. After all, they are multitasking. So there are other challenges which they are kind of external factors, but still parts like an internal factor, is the fact that trying to even use the regulatory bodies to put things in perspective might not even be easy because the regulatory body would only acknowledge those who are registered within them and would even want to make things difficult for those who are not registered. And for us who are in TB program, we'll go to where the patients are, where the burden is. We don't mind if you're recognized or not recognized. As far as you expect that they are presumptive here, you go there. So you see that the effort of the regulatory body to use the regulatory body to foster any process might not even favor as well the program. Then you also have the aspect of documentation fatigue. Of course, we are more paper in the program, and you keep seeing the difficulty for them to catch up with the loads of things that you need to record. The PPM, or it's also treated equally how the public sector is treated. So every indicator and every variable is very important in PPM because it's reported down to the last variable. In fact, we've onboarded GeneSpart, percentage I had GeneSpart, TB, HIV have all been onboarded in the PPM. Before, we weren't taking it so seriously because we just mop it into the total for the country. But now that segregation or disaggregation is now very required globally. So you see that even as a variable in the public sector is increasing or globally is increasing, it's the same thing happening in the private sector too. We're also having that loads of demand from them. Then the aspect of even having on-the-job mentoring from the local government supervisors are becoming very difficult because the expansion as is going on, you find the local government supervisor being more committed to the public sector than even the private sector. So the required on-the-job training might not even be happening to ensure that with this staff attrition that you are able to have maybe speedy replacement and also training. And of course, it's a profits organization, making organization, and they are always kind of focused on their profits. So to conclude, in spite of all, we keep on and we maintain these results. We've already started well in Nigeria and we already have the numbers. And one thing we would not do is to start nosediving. So whatever it takes for us to sustain the results and ensure that we keep up is what we'll do. So we might find sustainable means of reducing attrition. Do we need to train a group of staff? Like have a group of staff, like not just the nurses and the doctors and all that, but once they say, oh, these are TB focal persons, they say, can we have 3 or 4 TB focal persons? We train, but one is on the job. If one is not available, another can take up so that we have that speedy replacement. Then are we going to have regional or sectional master trainers for each of these cadre? So we know that at any point in time, we have master trainers. We can have master trainers for PPMVs, master trainers for CPs, master trainers for this. Then this will be the pool of trainers we can have in the program that can be deployed at any time, especially as we are having this increased attrition. Then we can also map the PPM centers. I know the IPs all know the PPM centers and be able to classify them based on the scheme. And we say, oh, these are the level of efforts based on the scheme of this. Of course, the PPM doing identification and referral will not need the same level as effort as scheme 3 or scheme 4. So these are all the things we can be looking into as a program to know what exactly would help us so that these numbers and this success that we've achieved doesn't nosedive. Thank you very much.
Thank you so much, Dr. Obioma. That was a very, very interesting presentation. So now I think that please, I'm sure a lot of us have a lot of comments, questions, so on and so forth. Please hold them off till when we come to the point of discussion. You can also begin to write your questions in the comment section if you have something that you feel like you need to drop and you don't want to forget. We will still get to it. But this was a fantastic presentation. Thank you. And a good background as well for all the other discussions. So now we're going to go ahead to start talking to implementing partners. I'm going to call on Dr. Adetipia from IHVN to share the IHVN experience of what they've been experiencing as far as capacity building is concerned. What are the challenges and what are some of the innovative ways that they have are in the process of addressing these problems. So Dr. Adetipia, please go ahead.
Thank you very much, Aji, for the introduction. I'm also thankful to Dr. Obioma for the opening. I think you have opened very well, and I'll just be building on quite a number of the things that you have mentioned in your presentation. So give me a second to share my screen. All right. Okay, so once again, I'm Dr. Temitope Adetiba. I work with the Institute of Human Virology, Nigeria, and I bring greetings from our executive management, who have been very supportive in making sure this program and this project takes off and is being implemented smoothly in the last 5 years. IHVN is an indigenous NGO in Nigeria that has a mission to be a center of excellence in providing health service implementation of good quality. And research is also one of our key areas, and ensuring that care is accessible and affordable to everybody in West Africa, irrespective of their age or socioeconomic status. We have a vision to be a leader in providing quality health services, capacity building, and research in West Africa. And this is also predicated on our core values of integrity, teamwork, innovation, transparency, accountability, excellence, and respect for the human person. This is going to be the outline of my discussion, but quite a number of the things I would have to say, like I mentioned earlier, have been really clarified by Dr. Obioma's presentation. And so I'll be telling a story of our experience in the last 5 years of implementing the Global Fund TBPPM grant in Nigeria. Just by way of an overview, this grant between 2019 and 2023 was the first Global Fund TBPPM grant in Nigeria, and IHVN was the principal recipient, and we covered 21 of the 37 or 36 states in Nigeria. We covered these states through our sub-recipients, and that you can see on this map. And the goal of that project was to increase the TBPPM coverage from 2.5% in 2017 to 31% by the end of 2023. Now, if you follow Dr. Obioma's presentation, you would see that we were doing quite poorly before this time, that's before 2019, as a country, with engaging our private providers in the TB response. And this also was reflected in our TB treatment coverage, which remained consistently under 24% for 10 years. And it became imperative that there was need for a paradigm shift if we were going to make progress with our TB treatment coverage as a country. And that was one of the reasons why there was a necessity to engage the private sector. We also have a goal that the private sector contribution to TB notification needed to increase from 11% in 2017 to 35% at the end of 2023. Now, with this in mind, we set out with our objectives for that project. We had our coverage, but I'll specifically just be looking at how we needed to engage all classes of providers. So Dr. Obioma spoke about the faith-based organizations. But before that, data already showed that in Nigeria, up to 60% of people access health services in the private sector for the first time. And so it's a no-brainer that we needed to actively engage the private sector if we were going to find and treat all the missing TB cases in Nigeria. And we also know that the health-seeking behavior shows that many Nigerians are comfortable with accessing care with faith-based organizations. So we knew that in the 21 states where we were working, we had to engage all faith-based hospitals or health service providers. We knew that we also had to engage other cadre of private service providers that I'll be looking at subsequently. Because of time, I won't go into exact details of what we actually did, but you can see on this slide that our scope of implementation included engaging these private providers. But how did we go about it? We went about this by first engaging with their umbrella associations. We know that all these private providers have their umbrella bodies. The patent medicine vendors have the agency that coordinates the activities. The community pharmacists also have their agencies. The private medical practitioners also have their professional associations. So we engaged with these professional associations and umbrella organizations to reach their members. And through that, we were able to do a mapping and assessment of these providers in every state and in every local government. And subsequently, we went ahead to do some capacity building training for the healthcare providers that were identified. And so this process of training involved us looking at the current national guidelines and training manuals. And we had to customize it to the specific needs of this cadre of providers. That being done, we set out to train doctors, nurses, patent medicine vendors, traditional healers, and all those groups of people. We had to customize trainings for their different levels and as we engage them. We also realized that we had to have a task mix for each of these class of providers. We know that a patent medicine vendor cannot go ahead to treat a patient for TB. The regulations don't allow that. And even the training those people have does not allow for it. So what did we do? We have a tax mix that says, oh, this class of providers can only go ahead to screen their clients for TB using a standard checklist and using technology that I would briefly touch on, which we had a mobile app developed specifically for this called the MATS, mobile application for TB screening. And once this screening is done and a presumptive is identified, we know that there is the next step, which is referral for diagnosis. And so all these structures were put in place. We had to strengthen the diagnostic network, and we also had to ensure that there was adequacy of recording and reporting tools for these processes to be well documented. And as Dr. Obioma touched on, we observed that the private sector in Nigeria, of the over 500 gene expert sites that we have for first-line TB diagnosis in Nigeria, only about 90 are in the private sector. So it just meant we needed to have a strong diagnostic network where samples can be referred from the private sector to the public sites for diagnosis and results returned promptly for treatment initiation. So I've summarized quite a number of the things you'll be seeing on this slide previously, and I'll be speaking to some of the strategies for the capacity building in the private sector that we deployed. So I mentioned deployment of MATS previously, and this really had to come to play because when you are dealing with private sector providers, one of the lessons we learned was that you are dealing with people who have a lot to do in the facilities that they manage. They don't have the luxury of assigning just one staff to do to play the role of a TB officer in the facility. And you have one person, for example, who is taking deliveries, who is attending to clients at the OPD, who is administering medicines on one end. So one person doing a lot. So we needed to make sure that if we were to ensure that all attendees, all clients are being screened for TB whenever they visit these facilities, technology had to come to play. So the MATS was developed, the mobile application for TB screening. And this ensured that it reduced the time a health worker would spend trying to screen a client. He comes, and once the app is launched on their mobile device, they can quickly run through the checklist of questions, and the application analyzes the feedback and quickly throws up the response, whether this client is presumptive or not. And if it's presumptive, the next step is to take their samples and off they go for evaluation for TB. Once confirmed that they have TB from the testing, if the facility is a spoke site, so I'll be talking about our hub and spoke model, which is part of the entire ecosystem that helped us achieve a high quality of turnaround from the health providers we engaged. That system ensured that we have a network that keeps improving the service delivery across the cascade, which I'll be touching on. That system where we have a hub, the hubs represent a private hospital, a private clinic, or a faith-based organization where you have a component of doctors and nurses who are highly skilled. So these doctors and nurses are trained to be able to render the range of TB services from screening to clinical diagnosis to treatment. And they are able to do that comfortably. And then they serve a cluster of providers that we call the spokes. These spokes range from patent medicine vendors, community pharmacies, traditional vet attendants and healers, and private standalone labs. And so these spokes are clustered around a hub So we have usually a cluster of 10 spokes to one hub, and the doctors and nurses at the hub can handle the referrals from the spoke. They also help with ensuring that the quality of services rendered by the spokes is in line with the national treatment guidelines. And so with that process in place, the spokes can screen and refer while the hubs do the diagnosis and the treatment at their level. And this is a system that enabled us to scale services, TB services in 21 states, and most importantly, collaborating with the umbrella organizations for these providers. So it enabled us to have a very strong network that ensured service delivery was optimal. We also put in place something we call the cascade review meetings. So through our SRs implementing across the states, we have—
Sorry to interrupt, Dr. Adetiba. I just wanted to let you know that you have 5 minutes more.
Thank you, Aji. So we have regular cascade review meetings where these providers come together and they can interact with us. We identify the challenges in the TB care cascade that enables us to know where there are issues and we can address those promptly. I already spoke about the maths. This is just a schematic of how it works, which you can view much later when we share the presentations. So with this engagement, in 5 years, we were able to build the capacity of more than 20,000 private healthcare providers across 21 states. You can see the distribution of those providers here. And I'm quickly moving on now, just to show that at the end of that 5-year period, you can see in red font the reporting rate from these classes of providers. One thing that will strike you here is that the performance we achieved over those 5 years, where we were able to screen over almost 20 million individuals for TB and diagnose more than 200,000 TB patients, was largely due to the effort of those non-conventional providers that we call the spokes. So we would have missed a lot of TB patients in Nigeria if we did not build the capacity of providers that we call the spokes, those that are not conventional hospitals, that are not traditionally engaged to provide TB services. And that's what you can see on this slide. Our patent medicine vendors were responsible for more than 50% of all the notifications that I just described from the private sector in that 5-year period. As I quickly run along, Dr. Obioma has highlighted some of these things. That's why I can skip them confidently. I'm just looking at some of the top 5 performing states in our grant of those 21 states. Sokoto State is #1 here. They've remained our top performing state in these 5 years. And I'm happy we have a provider from Sokoto State here who will be sharing their own experience. But what is critical from Sokoto State is that there was strong engagement of the private sector, most especially the spokes, knowing the health-seeking behavior of people in Sokoto State. A lot of them would rather go to the spokes whenever they are ill, no matter how serious the illness is. And we identified that once we were doing our assessment and mapping. We focused on this group of providers, gave them the skills and the tools to be able to do TB screening and referrals, and also to ensure prompt diagnosis. And you can see that in 5 years, over 20,000 notifications from the private sector in that state, and 15,000 of those came specifically from the spokes. So these are some of those 5 states and the winning strategies that we deployed in those states. I will just go, as we conclude, to some of those challenges with capacity building as our topic states. High staff attrition, and we notice this particularly in the hub sites. This is not really much with the spokes, primarily because they are a one-man business and they require to continue working to earn their daily living. But with the spokes, where we train doctors and nurses, most especially, that is where we see a lot of attrition. So what do we do? And how were we able to address this? We could not address it completely, but we put in structures such as on-the-job training and mentoring. So this was done largely by our teams that were domiciled in the States, that's the SRs. The linkage coordinators kept on doing on-the-job training for the new staff who were engaged. We also had continuous mentoring from the local government TB supervisors. This really helped us to ensure that service delivery was not interrupted. We also needed to work closely with the umbrella organizations to help us continue to mentor their members who newly joined our program in the course of implementation. Because we know that gathering people to train them for 5 days is not practicable in the real sense when you have to deal with a large number of private providers who need their staff to be at work. So that's one of the key things. We had other issues that are not really related to capacity building that I brought up here, but I would not major on in this presentation. So, but looking ahead, what are the things that we're putting in place? We're in another cycle, the Global Fund Grant Cycle 7, which began in January. We are already in discussions with the TBPPM Learning Network in Nigeria about a mentor-mentee program. With this mentor-mentee program, the way it would work will be that where we have very strong and established private providers, they would sort of become a pool of facilitators, something that Dr. Obioma mentioned, who would be able to quickly intervene wherever we have staff attrition or a new facility coming on board within a vicinity. This mentor facility or mentor facilitator, who is also a healthcare provider themselves, will receive support from us, and they can go and train their colleague and ensure that they are capable of offering TB services. We believe this is something that will really go a long way. Another innovation that we came up with that was graciously approved by the funder is to develop digital training platforms where private care providers, especially doctors and nurses, can access those trainings digitally and at a pace that is self-paced, so they can get trained self-paced. They are also assessed, and at the end of a period, they are certified to be able to offer TB services. So this is done virtually without really having people travel to go and train them. And so this is something we look forward to seeing how it will work in this current grant cycle, and we believe it will really be a step in the right direction. Lastly, I will also want to mention that TB and HIV service integration is something that is big on the mind of everybody right now. So on this project, we are seeing that how do we build the capacity of private health providers not to just offer TB services, but also HIV services, so that once they are seeing a client, they can offer holistic care at that sitting. And this is the way to go. We believe all these services should be integrated so that our efforts can really strengthen the overall system of healthcare in Nigeria. Thank you very much, and special thanks to our partners who made all this possible in the last 5 years. I appreciate you.
Thank you so much, Dr. Adetiba. That was really, really interesting and very informative. So I will look forward to having a lot of people have already decided to put questions to you, so we'll answer that after the other presentations. So at this point, I think that the national coordinator has joined, if I'm not mistaken. Stella? Yes, good afternoon, sir. Thank you for joining.
Good afternoon, my sister. Am I on?
Yes, please. You have the floor, sir.
Oh, thank you so much. I'm glad to meet you and to meet this discussion at this level. I'm sorry I have to join you late. I've been anchoring the meeting since morning in one way or the other, but I'm happy already informed us some days ago. This, of course, is a welcome idea to the National TB Control Program. We then need to sit physically one-to-one to start having discussion on how we can forge ahead the program. As you are aware, of course, engagement of private providers is one of the key components of Stop TB strategy, which of course the national program is buying into. Been hiding in private sectors, in these areas. We have to make effort to bring our cases out, and been part of this system like 10 years, when we call it PPMix. Now, especially by our partners. I must commend the organizers, that is the PPM leadership, right? So we have done well, and I think we must commend you for organizing this training or this meeting. So sustainability is the key word in whatever we're doing. So whatever we're doing, we should bring innovation, and we should think out of box, so that these people that are training, of course, attrition is a factor. When you train, you will not see them again. The Japa syndrome has been on ground, but we have to find a way of sustaining this training, so that those that are on ground should be a mentor trainers to those that are new, and whatever support would they need from the national program were on ground. I'm impressed with the last two discussants, Dr. Obioma and Dr. Adetiba. They have technically digested the topic of the PPM, the collaboration, the training, how we're going to sustain it. But obviously, on the side of the government, we have also taken it very serious. In fact, in line with the 4 key agendas of my minister, Professor Pate, capacity building is a key in our human resource, especially those that are delivering services all over. So in doing so, we'll not forget the PPM component. We are also going to engage them in most of our activities, especially at the partnership meeting, when we have forum where all partners will come and make presentation. We'll look at their challenges, how we are going to integrate them into the government very well. So this is a welcome idea, and the national program, of course, with the ministry, I think we have problems when it comes to integration. We have to look forward for PPM to come in as we integrate them, not only TB HIV, but all other diseases. If you go to the private sector, they don't treat only 1 or 2 diseases. They do antenatal, they do delivery, they treat communicable diseases, non-communicable. So we usually use it as a forum to see how we integrate, train them so that they can deliver all these services. And this is what the government is looking forward for. I must congratulate all of us for holding this webinar, and it's a welcome idea, and especially the organizers of this activity, that is the TBPPM Learning Network. I must congratulate you for well done. Thank you.
Thank you very much, sir. Thank you. We're very honored to have you.
And I wish us a fruit. Thank you.
Yeah, sorry about that. Thank you. We're very honored to have you despite your very schedule.
Most people don't know me in my new capacity as the national coordinator. I'm Dr. Labarashiu. I'm a director with the Federal Ministry of Health. I'm just settled into the responsibility of anchoring the national coordinator. But my work is to coordinate and at the same time mobilize resources for you, subsequently also to support the program. But majority of the work is being done by you. Certification has risen to a substantial level, and also the treatment outcome. All this goes to the effort being made by individual partners, IPs, and all those that are helping the program. And we appreciate you all for all the effort you're making. Thank you.
Thank you very much, sir.
Hello.
Yes. Sorry, Stella, we can't hear you. It looks like there's some.
Yes, sorry. I think you can hear me now.
Yes, I can hear you.
So I said we would like to bring up the next presenter before we start taking questions.
Yes.
So I want to call on Dr. Sheshi to make his own presentation. Thank you. Dr. Sheshi, are you there?
Yes, I am. Thank you, Stella, and good afternoon, good morning, good afternoon, and good evening, everyone, and welcome to this webinar series. So I'll be presenting the capacity building for private providers for TB services in Nigeria and sharing a little bit of the experiences from KNCV Nigeria. The first two presenters have really laid a lot of groundwork on what I need to speak about. And I think I will just go straight into the subject matter. This is the outline I will be using. I will just go on ahead. So a little bit about the background of KNCV. KNCV has been supporting the National TB program in Nigeria in control of various diseases of public health importance for over 20 years now. KNCV as a brand is an international organization with the headquarters in The Hague, and they started implementing in Nigeria somewhere in 2004. But then somewhere in 2016, we started trying to lay the groundwork to have a local indigenous NGO, still going by the name of KNCV. And that was successful. By 2020, we took off as a local organization, and we have several projects to our name at the moment. Just a little bit of the spread of our projects across the country. We virtually have a presence in all of the states in the country through our portable digital X-ray projects, but then our major work is the TB Long 1 and 2 projects, colored green here, which we're implementing across 14 states in the country. So going directly into the private sector for TB control, just to state that all of the projects we implement in KNCV Nigeria support private sector TB control. There's usually a private sector component when we are doing the design of most of our projects. However, the major focus for private sector engagement are two of our projects, the TB Long 1 and 2 project, which I stated we are implementing across 14 states in Nigeria, and then the Global Fund Community PPM grants, which we are implementing as a sub-recipient to IHVN. Dr. Adetiba had presented a little bit on this in his presentation. For the Global Fund Community PPM grants, we are currently implementing across 7 states in Nigeria. Now, just to talk a little bit about our strategies before we go into what we are doing for the capacity building, sustainable capacity building, we have about 5-6 strategies which we use when we are dealing with the private sector. Chief among that is that we try to engage all care providers. Dr. Obioma had talked about this, and the TB program in Nigeria, we try to go where the patients go, and so we look for those facilities that patients are likely to visit for their healthcare needs, and we try to engage them for TB control. The hub and spoke model was also discussed by Dr. Adetiba. It's something that most of the partners implementing in the private sector space in Nigeria use, and we found out that it's really beneficial. And then for us in KNCV, we even use it as a capacity building platform. I'll talk about this a little bit later. Now, we have mixed implementation models. In some states, we implement directly. In some other states, we engage a sub-recipient who does the engagement of the private facilities on behalf of KNCV Nigeria. At the heart of what we do in the private sector is to realize that these private providers are there for profit making, and then we have to speak the language that they understand. And so we usually implement what we call a negotiated business model with these private facilities, discuss with them what services we would like them to provide, and then what will be in it for them. Now, beyond monetary benefits, of course, we also try to look for things that will motivate these private providers. So we sort of give recognitions and awards for people who have outstanding performances, try to engage them with the state TB program and the Federal Ministry of Health. And we've seen that that's really a big motivator, and that really helps us in the implementation in our states. Now, we try to be flexible in all that we do. The private sector is an ever-changing space, and for us to keep up with them, we would also have to be flexible in our implementation. Just to talk a little bit about just giving in numbers what we've been able to do for the TB Loan 1 and 2 project. This is the outcome of what we've been able to do across the years. We started in April 2020, and we can see that there's been a steady increase in the case finding. Now, the yellow bar is the cumulative case finding quarter on quarter, but the blue bar is specific for the private sector in the TB loan project. And we can see we are currently close to 10,000 TB cases notified per quarter from the private sector. That's really a lot, and we are really pleased with that. Now, for the other big private sector project, the Global Fund Community PPM project, also giving a snapshot. This is a subset of what Dr. Adetiba had presented during his presentation, but we can see there's also an increasing trend through the years, which the project started in 2021, and as at the end of last year, we're diagnosing about 6,000 TB cases from the private sector. Cumulatively, from the TB loan and the Global Fund grants, we diagnosed close to 15,000 TB cases across our supported states, and it's something that is really huge, contributes significantly to the TB case finding in the country. Now, just to summarize our PPM implementation, it's something that it's been on the increasing trend ever since we started, and then we carry out our implementation in a hub and spoke model that has been talked about, we usually maintain that model for ease of activity implementation. Now, for us, with the huge number coming out from the private sector, the quality of care is something that we are really, really looking at. And then, of course, we can't maintain that quality without adequate capacity building of these private providers. And we try to implement these capacity building measures in all that we do. We've talked about staff attrition and the challenge it poses to PPM implementation, and we'll see how we've been able to mitigate that. So just to talk a little bit about the challenge, across the two projects I've talked about, we have about 7,000 providers engaged across these two projects. We can see the numbers for each of the grants, and this is really huge. You can imagine the investments that will be required if we're to reach all of these participants one-on-one and give them trainings. It's really a huge, it will really be a huge investment. And added to this, in these new grants, we're even adding a lot more than these numbers. We are currently trying to carry out some trainings across some private providers. So there are really a lot of private providers that really needs to be reached with capacity building modules. Now, of course, as Dr. Obioma said, we try to suit the needs, the training needs, according to the need of the provider. Not one size fits all, and we have to train them based on what they really require. Sometimes, as Dr. Obioma had mentioned, we even have to speak in the local dialects that they understand. Now, for us in KNCV, what we do is that we make sure that for the initial engagement, we do capacity building, a physical training where we're able to meet with the people and build their capacity based on their needs. And then from what we have also observed, there is a need for some sort of refresher every 2 years, and I'll tell us how we're able to do some of this. I've talked about the funding required for trainings. It's really huge. And then, of course, the issue of staff attrition, which is currently in Nigeria at an all-time high. Still talking about the challenges, in a study carried out in Lagos by Adepoju et al., it was found out that the providers, the percentage of providers that had the median knowledge of the international standards for TB care was just at about 47%. And Lagos is usually the highbrow state where the knowledge level of providers is usually a lot higher. So in other states, it's likely to be a lot worse. Now, staff attrition also bringing a very, very big problem. In some states, it could be as high as 50%. You train people today, and when you come back in a year's time, you find out that those people that you train have gone. What have we been doing in KNCV Nigeria to bridge this gap? As I said, the initial training, we try to make it a physical training, and we put that in our budget planning to make sure that all of the people we are going to engage, we have a one-on-one with them at the time we are engaging them. Of course, this is different based on the tier. Dr. Obioma talked about the 4 tiers. So for tier 3 and 4, we do a 3-day comprehensive training. And usually for the tier 1 and 2, we just do a 1 or 2 day training depending on their training needs. And of course, this is based on the activities they will be implementing, and we make sure that it is well understood. We do this with the state TB program, who also helps to build the capacity and follow up even after we have done that initial training. Now, we also support the facilities with mentorship and supervisory visits. So for us, any opportunity we get to meet with these private providers is a capacity building avenue. When we meet with them—
Sorry to interrupt, just wanted to let you know you have 5 more minutes.
Yes, yes. So we use the every opportunity that we meet with them just to talk with them, to understand the capacity gaps, the knowledge gaps that they have. And then we try to sort of address those gaps, give them reorientation and mentoring on the job. We found out that this is usually very effective. If we're able to meet with private providers in their own facilities, they are more at ease, they are able to assimilate these things more. So usually when we do the first one-off training, we also follow up with these mentorship visits. And usually we try to make sure that one of our field staff, if they're the linkage coordinator or program staff in the state, meets with a provider at least once in a month. And that serves as a capacity building process. We also carry out refresher trainings, not really large scale like that. We just select some of the providers who we feel will need this capacity building exercise. And then in small meetings, usually some of the review meetings that we have with them to review some of their work, we now train them on one aspect or the other of the TB control program to build up their capacity so that they are able to carry out the implementation based on the national guidelines. Now, we also try to utilize the private provider associations to also help us in the capacity building. Dr. Aditiba had talked about the fact that right from the engagement process, we try to ensure that the private provider associations are carried along. So we work with their management and we give them quarterly feedbacks, and we sort of utilize them to do some level of capacity building. We show them the gaps, and they also help us. We may not be able to go every day or every week to the private providers, but then these associations, they have their mechanisms where they are able to meet with these people and they are able to convey the messages that we want to convey. Now, another thing that we do through these private provider associations is the fact that most of these private provider associations, they have monthly meetings or quarterly meetings, depending on the association. And we try to be a part of those meetings and give a 10, 15, 20 minutes TB talk on how to get the presumptives identified, diagnosed, and of course, treated. So we're able to use that to get to a larger audience. And then we've also been able to improve capacity through that avenue. Of course, we also try to link this private provider association leadership to the state TB program so that they also know the goal and the focus of the state TB program. I've talked about flexibility and innovations. We try to be flexible in all that we do. We fully understand that the private sector is a mixed group, and one size will not fit everybody. So we try to be as innovative as possible, provide incentives and non-financial incentives, and also do some level of studies to find out what really works in the private sector. And of course, when we find out what works, we publish it and disseminate for other people to use. Now, there's one innovation which we have introduced. We had to introduce this during the peak of the COVID era. We actually started this not in the private sector. We had a lot of ad hoc staff, over 1,000, and it was at the peak of the COVID. We couldn't gather them in one place to be able to train them. So we developed a competency-based training, which is a web-based application where people are able to be trained at their own pace. It's a self-paced training platform. So people are given login details, and based on their needs, they get training on specific activities. It could be for people providing TB services, for people providing laboratory services, for people providing referral services. There are different modules there, and depending on the service they provide, they have that training done. As we said, it is self-paced. People log in, and at their own time, they take up the training, and we are able to assess them. Now, after the training, there's a there's an assessment that is carried out, and based on the score of the assessment and the number of tries they're able to get that score, we're able to profile those who will further need one-on-one mentoring, and then we carry out this mentoring for those people. As I said, we started this with our ad hoc staff, but we're able to see the benefits of this competency-based training, and we escalated this to even the providers. We are currently providing this service to providers of TB services, both in the private and in the public sector, and we found out that we're able to reach a much larger crowd with the use of the CBT. It's completely free, and people are encouraged to do it. And then, of course, when we find out that you need further one-on-one coaching, we're able to deploy our field staff to give that coaching as required. Since the inception of this CBT platform, we've been able to enroll over 3,000 people on it. We would not have been able to do this with our conventional training methods, and over 80% of these people have fully completed the training modules. For us, this is one of the ways to go, and we are hoping that in the coming years, we'll scale up this and even make sure all our providers have access to this CBT platform, and we're able to keep them abreast of what they need to be doing. So in conclusion, for us in KNCV, there's no single approach that works for the private sector. We have to be innovative. It's something that we have to continue doing, continue trying out new things, continue being innovative, and see what works. For us in the private sector, we'll continue to have better collaborations, more innovations, and more flexibility to ensure that we're able to meet up with the demands of the private sector. We have been doing this, and hopefully even in the coming years, we'll continue to do this to improve the private sector contribution to TB control in Nigeria. Thank you very much. That's all from us in KNCV.
Thank you so much, Dr. Sheshi. That was a very, very interesting presentation. And it's really exciting to see a lot of the work that you're doing. So now we've heard from the program, we've heard from implementers and how they're dealing with these issues, the innovative ways that they're dealing with it. Now we want to hear very, very briefly from private providers. So how is it from their own side? What are they experiencing? What does it look like from the other side of the table? So I'm going to invite Aliyu Usman from Sokoto to give us a really brief overview of our capacity building and how their own experience has been. Please go ahead, Aliyu. I think you're still muted. Joe, are you able to unmute him?
Yep, I've sent a request for admin.
Aliu, can you hear us? Yes, we can hear you now. Please go ahead. You have 5 minutes.
Can you hear me?
Yes, we can hear you, but we no longer can see you.
Yeah.
We can see you now.
Yeah.
We can see you. Please go ahead. Yeah.
All right. Okay. Good afternoon. I'm Ali Usman from Sokoto. I'm one of the. Okay, can you speak? Okay.
Yes, we
I'm
can
Ali
see you.
Usman from Sokoto.
Go ahead.
I work in Al-Shifa Clinic and Medical Services. So I'm one of the hub over there. Okay. So I work in Al-Shifa Clinic and Medical Services in Sokoto and Lenos. So
it looks like we may have lost him. So while we wait for him to rejoin, Emmanuel, do you want to go? So Emmanuel works for a standalone lab, and so we wanted to also hear from a private provider from that perspective. So Emmanuel, please go ahead and unmute, and you can speak while we wait for Ali to rejoin. You have 5 minutes.
All right. Good afternoon, everybody. I'm happy to have joined this meeting. I thank all the speakers who have spoken so far and have helped to shed a lot of light on strategies of sustainable capacity building for private providers of TB services in Nigeria. My name is Emmanuel Onyeje. I'm currently the General Laboratory Manager at L Lab. Immediately, some weeks ago, I used to be the gene expert focal person. So today I want to share our own experience, the LLab experience of engagement and involvement in TB services, especially as a standalone lab involved in diagnosis of TB. Especially, we came to limelight the TB program by using the Gene Experts, making TB diagnosis using the Gene Experts platform. LLab is an indigenous laboratory with the ISO 15189 international accreditation for provision of laboratory services in hematology, immunoassay chemistry, serology, microbiology. Established in 1998, has been operating for over 25 years now. We came into the TB program, especially using the Gene Expert platform, in September 2018, when Ella became the first private standalone lab to host the Gene Expert machine as a gift from the federal government. And since then, we set to work assiduously, running samples, Gene Expert samples, and churning our results. And we've contributed immensely to the diagnosis of TB in Nigeria. In 2019, we emerged as the top testing laboratory in Nigeria. And then by December 2020, we became the first laboratory to host the 16 module Gene Expert machine. So up to this day, we are still at the forefront of provision of diagnostic services for TB. Today, we want to talk about how have we been able to sustain services over the years. First and foremost, the key to the success of LLab's involvement in TB diagnosis has been the will of management. My boss is as a stakeholder in TB services in Nigeria and has personally taken it upon himself to pave the way for the involvement of other private sector providers, especially in TB diagnosis. He has always said that his aim has been to demonstrate what the private sector can do. and that has actually we've been the trailblazer for the involvement of other private sector providers or standalone labs, involving them, other standalone labs in the diagnosis of TB. And today we know that other standalone laboratories are hosting the Gene Expert machine, other standalone laboratories are hosting the TrueNat TB diagnostic platform, and also the TB Lamp as well. The LLab success story has actually paved the way for all of these top high sensitive diagnostic platforms to be used in all of these other placed in these private facilities. So first and foremost has been the wheel of management. I want to encourage program coordinators, recipients of funds, sub-recipients of funds, directors of programs to, as part of their strategy, which has also been highlighted, but just to espouse that it has worked for us to always canvass and seek the support of management to ensure that programs are properly implemented. We've highlighted the issue of, many of people have talked about issue of staff attrition, but you bear witness that even with the rate of staff attrition in these facilities, that these facilities don't close. They still offer their other services. They still offer, if it's a laboratory, they still offer laboratory services for clinics, hospitals. They still see clients. So the fact that the staff attrition in these facilities shouldn't warrant the closure of TB services. If that happens, it means that TB services has not been properly integrated into the mainstream services provided by that hospital. Is still being seen as activity that occurs by the side. But so I encourage program directors to work towards integration of TB services into the mainstream services offered by those hospitals. And of course, we're talking about for the private standalone labs and the private for-profit facilities. We should be talking about what's in there for them. We've seen the statistics, we've seen the data, we've seen the results of the changes this has brought into the TB program in the long run. We've seen the data, we know of patients treated, success stories, and we know that the fact what role the private sector has played. So we should be, in writing for grants, planning for grants, planning for expenditure of funds. A lot more has to be invested into letting having something in it for them. We talk about negotiated business model. For instance, recently we talked about an X-ray machine, for instance, being placed in a facility such as LLab, and then the patients being accessing these services for free. And then also the facility can use this place equipment to carry out their own business. So this is also a model that can work. So it must be a win-win situation. Just as the program hopes to get something from these facilities, we need data, we need results, we need patients being treated, cases being identified. So also the facilities there must also be something also for these facilities that are out to do their business. So wheel of management, then must be something for the facility as well. Then also a lot of staff must be engaged.
Sorry, we're running out of time. Can you please just round up?
Okay, so just finally, more than one person must be trained at once. I always advocate that if nurses, doctors, scientists are being trained, a lot in these facilities should be trained, not just the focal person or the assistant focal person. You must be carrying the facility staff along. So as I said earlier, the wheel of management, it must be in something for the business, and then also much more persons should be trained in each of these facilities to avoid a situation by when one or two persons are leaving the facility, it will lead to stoppage or to lead to stoppage of TB services in those facilities. All right, thank you so much for having me.
Okay, thank you very much, Emmanuel, for your summations. I think they're very, very relevant and it's nice to hear from the side of private providers. Unfortunately, Aliyu has not been able to join us back, but I think that you on your own have been able to give us a good feedback in terms of how the private provider is seeing it. And I think it's also a very important point you're raising about the will of management. It definitely makes a big, big difference in capacity building and every other thing. when the private providers are actually as engaged as the public sector in offering TB services. Yeah, so now okay. Ali, you seem to have joined. Can I suggest that you switch off your video, because I think that the network is very poor, so that maybe the network will be stronger if you do that. So maybe just switch off your video and then give us a really quick summary of capacity building from your own perspective. Thank you. Ali, you have the floor. Please go ahead.
All right. Good afternoon. Can you hear me?
Yes, we can hear you.
Hello. Okay. Good afternoon. Ali Usman. I work in Al Shifa Clinic and Medical Services in Sokoto. So I'm one of the TV staffs in the clinic. So the introduction of this public-private mix has really helped a lot in detection of TB cases, because T20 that I was in the program, there is a lot of changes in the detection of cases, because Sokoto is one of the states that has major TB cases or more TB cases. So introduction of this PPM has really helped a lot, because almost all our cases in the clinic are being gotten from these PMVs, that is patent medicine vendors, and very hard, including the TBS, because they do go through, they do go around the communities, because all these cases are gotten from the rural areas. So all these TBS make sure they go through the rural areas and fishing out of all these cases, because Sokoto is a place whereby, you know, in terms of let me say, in terms of religions, not all the married men have been opportune to come out of all these traditional birth attendants. So they have access in talking to the women and make sure they have good understanding with them, to have good understanding, so that will give them access to have questions with them and really find out if it's a presumptive case or it's a case. So apart from that, in Al Shifa Clinic, a lot of cases being its high burden facility, so we have many cases being referred from the PMVs and TBS. So we also have a COF officer. So, and I think the COF officer has a lot doing, because of the number of cases. Yes, if there's a means, we should add a COF officer. There should be 2 in number that will help in screening the patients. So another thing is, let me say, sputum to lab. We have laboratory centers, let's say gene expert centers, which helps a lot in making the work easy. Let me say, making the work easier, and all these sputums are being sent to the gene expert site. Let's say 2 to 3 times in a week, which most of the time they don't disappoint. The result will be out in 2 to 3 days. So the little challenge or challenges we are facing, I would say, is that of insecurity, because we have insecurity challenges in Sokoto State. And with this insecurity challenges, those people in the rural area won't be opportune to come into the urban settings, and they won't be opportune to come into the urban settings. So as such, there will be reduction in the rural setting, but we won't be opportune to they won't be opportune to have access to the private and public settings because of insecurity. So I suggest there should be increment in all these private settings. Let me see private settings that are closer to the communities. As such, the rural people or individuals will have access to the private settings. Has actually been of help to Sokoto State people, because as of the time where there was not introduction of all these PPMs, there are really cases you won't have access. You won't have access to the cases because some people are not opportune to come out of their houses. So this
Aliu, please,
PPM
can you round up?
Okay.
Yeah.
So this PPM has really helped a lot. So, and let's say the another challenge is that of the what's it called? Is that of the coordinator, language coordinator. So the linkage coordinator, they are trying their best in terms of supervision. So they try their best in terms of making sure that all the facilities have adequate drugs and equipment. So they also try their best. So I think what TB and leprosy mission should do, including the HIVM, is to train more staffs. Yes, is to train more staffs. Let's say more health workers in a particular private setting, because at times the people working there might decide to resign their work and go looking for another job. So after you've been trained with your experience, you just go. So the people there are not being trained and they don't know how the work is normally done. So I suggest more health workers should be trained, and they should be be shown how to. There will be more with this. There will be ease for the work, and there will be, let's say, there will be more cases. Yes, there will be more cases. More cases will more cases will. Sorry, I don't know how to put it. So, but I know if they are trained, so they will get to if they are trained to. Yeah. All right. Thank you very much.
All right. Thank you so much, Aliu, for sharing your perspective. And so now I think we've come to the end of all the presentations and all the talks. So we're going to open the floor and allow people to share, or any participant, whatever questions you have, whatever comments you have, please go ahead and begin to share. So we will, so if you can just raise your hand, if you have a question, you can raise your hand or put a comment down in the comment section so that we can organize the flow of conversations as opposed to just having everybody rush at once. So yeah, but the floor is open. So please go ahead and indicate that you have a question or that you want to speak. And I can see that some questions have already been ongoing. So people have put up questions, and some of the presenters, thank you very much, have already begun to respond. So as an audience, please feel free to go to the Q&A section and see some of those questions and answers, because for those ones that have already been resolved, we're not necessarily going to bring it up again. But if you have any new questions, or if your questions have not been responded to, please indicate. So sorry if I murder your name, Tile.
Yes. Can you hear me?
Yeah, I think you're able to speak. Please go ahead.
Okay, thank you so much. I have heard like lots of presentation, like they were very beneficial. I'm from Ethiopia, actually. I'm from Ethiopia. I work for the USAID Eliminate TB project under MSH. So I have like one question, maybe two questions. So maybe it can be like the question for like maybe for the program leaders from KNCB or from the.
All right, I can't hear you very well. I'm not sure if other people are hearing you loud and clear, but it's a bit muted. So if you can maybe speak louder or come closer to the mic.
Okay, what about now? Can you hear me now?
It's slightly better, I think.
Okay, thank you. So my question is like your capacity building method or your training materials, are
Perfect.
they okay? So your training materials in Nigeria, like, are they different for private facilities from those one like used to train public health facilities? Like, in short, do you have any customized training material for PPM facilities? And my another question is like for Emmanuel, for the private sector, from the private sector. So he mentioned that they have like the gene expert machine from the federal government. So how is the patients or clients, do they pay? How is it like going on, like, and as well, like, how is like, are you serving only your patients, or do you accept like samples from other nearby facilities? And what kind of sample referral technique maybe are you using like to do that? Thank you. I'm from Ethiopia. Thank you.
Thank you, Tile. So I'll let maybe Dr. Adetiba or Dr. Sheshi respond about whether or not they're tailored. I think you've already mentioned a little bit of that, but maybe you can give a little more detail. And I think, yeah, Dr. Adetiba, since you're here, you can also still explain, respond to the second question about how the services are provided through the private sector, who is receiving it, whether is being paid, blah, 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 blah. Please go ahead.
Okay, thank you, Tile from Ethiopia. We appreciate your questions. Regarding the training manuals, so the country already has a standard healthcare provider training manual and guidelines, which is used across the country. But because of the context of the various private service providers, for example, the patent medicine vendors, they cannot digest, or they don't need the entire training manual for their own type of service delivery, which is to screen and identify presumptives and refer them for diagnosis. So we tailor it to their need from the main national manual. So it's tailored for the needs of this class of providers. It's not really different from what you would see. And then we also know that the language that some of these people can understand, for example, if you are talking about hemoptysis, which you will see in the national guideline, they cannot relate with those terms. So we would use simpler terms like coughing of blood, and would make it easy to absorb the information, digestible for them. And also remembering that the average national training would take up to 5 days, but we need to condense what they need to just 2 days. So those are all the things that we consider, and we have training materials for them full of pictures, annotations, and easy for them to interact with. Regarding the service delivery in the private gene expert sites, so TB diagnosis and treatment is free in Nigeria at all levels. And that's one of the good things that the Nigerian government has put in place. And so to be able to access free services, even in the private sector, What this means is that we have some support from our funders and even from the government in terms of the commodities, the consumables, the reagents. They are provided to these labs by the National TB Program so that the service can remain free to the patients who need them. Thank you.
All right, thank you, Dr. Adetiba. So I will read out some of the questions that have not yet been responded to. There's a question from Kola Oyediran that says, is there a linkage between public health and private providers? So I think the question is about whether public facilities and private facilities, if there's any linkage. At least that's what I'm assuming. So if I'm wrong, Kola, please let us know. So if, for example, a case is identified in the private sector, is there any way that it's linked to what's happening in the public sector and vice versa?
Okay, maybe I'll take that. Yes, Kola.
Sorry, before you continue, Kola has his hand up. So Kola, can you unmute yourself and just maybe explain your question so that we can answer you better?
Well, you get it right. I just have another question, but Dr. Obioma, thanks, Dr. Seshi, thanks so much. So I just have another question, but I think Dr. Seshi can go ahead and answer that, and if time permits, I can ask the other one. Thanks.
All right.
All right, thank you. Yes, I was saying, yes, there's definitely a linkage. In fact, for us, PPM is public-private mix, and there's that linkage between the public and the private. Now, most of the diagnostics are in the public sector. Yeah, we have about 500 of the gene experts across the country, but over 400 are definitely in the public sector. So many of the private facilities do not have those gene expert facilities. So we've made a sample referral network such that presumptives identified from the private sector there are moved to the public sector for testing. Of course, some of the private providers may decide not to treat, they just want to identify and refer, and we're able to link them up either with other private facilities or public facilities that are close to them. So there's a lot of collaboration between the public and the private, and the state TB program headed by the program manager at the state level, and of course the local government TB supervisor at that level, supported with the partners implementing their hubs to make sure these linkages are optimal, and we're able to better serve the patients. Thank you.
Thank you, Dr. Sheshi. There's another question that I will read out. And Murrens, is there a difference in staff attrition numbers for urban and rural settings? And what is the primary reason for staff to move out so quickly? Do they move to competition or other branches of the industry? Is it salary driven, job satisfaction? So why do we have staff attrition? So anyone can feel free to answer.
Okay, maybe I'll start, and then Dr. Obioma can lend her voice. So yeah, there are various factors responsible for the staff attrition, and you need to understand the context at that local level to be able to understand what really drives staff attrition. Now, generally, the private sector in most of the areas in Nigeria does not pay as much as the public sector when it comes to the remuneration of the staff. And so, of course, people are always looking for government jobs where they'll be able to go and have better pay. Sometimes the pay may be at par or even a little bit higher, but then, of course, the duties you would need to perform in the private facilities are a lot more. So your workload is a lot more, and people who are trying to look for a little less of the workload will want to move to the private and to the public sector. So yeah, the remunerations drive this, the job satisfaction and all of that also drives it. But then even beyond that, as a country as a whole, because of some of the economic issues in the country, people are even looking for greener pastures, going out of the country, going to European countries where the pay parity is a lot better than what they will earn in Nigeria. So aside moving within facilities in the country, people also move out of the country. And that's something that we also have to contend with. And we also have to make plans for that when we are doing our program implementation. Thank you.
Yeah, thank you. Especially health workers. There's a great exodus of health workers out of the country right now in Nigeria. So thank you. Dr. Obiang, do you have anything to add to what Dr. Sheshi has said about staff attrition and why?
Okay, so I think Dr. Sheshi has summarized it. From the part of the Ministry of Health, if you look at human resource for health, there's always this migration from rural to urban. And even when some factors like factors of advantage has been set to attract more people to the rural, you still see that you still have a lot of these human resources moving to the urban area. So it's kind of keeps depleting. And the reason why this period it's somehow like as if it wasn't is because with the syndrome of skilled workers immigrating from Nigeria, there's now a lot of space even in the public sector. So you see a lot of hospitals even advertising to have more healthcare workers move, like hospitals in the urban areas, tertiary facilities, secondary facilities, you know. And sometimes recently we've seen that those call for application, some of the requirements are kind of seems as if it's even a little lower than what it used to be before. So the it's no more as difficult as it used to, because what's presently it's the hands that are being looked for to ensure that these places are occupied for the services they render. So you see a whole lot of these workers from the private sector moving to the urban, and now in the urban, they're moving into the public facilities, of course, because public facilities have structured ways of pension, like life after services in the regular services. So, and everybody's looking for security where you'll be able to get maybe a gratuity pension and all that. You're very certain that is secure. So staff attrition, it's there at all levels. So even the public is still suffering that same thing. But the only thing is that the cushioning effect in the public is that it's the way the system is, like it's government owned. So you always have 2, 3, 4 people at a setting working over something. So it's always easy to have someone appointed or moved in. But for the private facilities, you know, they're kind of enclosed with the number of staff. They just take what they need. So one person leaving, it's a lot of strain for the facility and the need for them to, and you see, by the time they start feeding into to even cushion the effect in the other areas where they feel it's like a primary purpose for them, like O&G, the internal medicine first, they will want to fill those spaces before they even get down to the TB. So you see why we need to do a lot of work from our own side to ensure that this effect is cushioned for the program. Thank you.
Thank you, Dr. Obiama. So there's another question from Paul Ifeanyichukwu. My question is directed to the second presenter. So second presenter, that will be Dr. Adetiba from the private best practices for PPM. How were you able to optimize turnaround time when you said results do come out within 2 to 3 days, as you said during your presentation? I don't know if you understand the question, Dr. Adetiba. Dr. Adetiba, you're muted in case you're talking.
Okay, my reception was not quite good. Can I clarify that he's asking about the turnaround time for gene expert tests?
I'm not sure. So, Paul Ifeanyichukwu, if you are in the house and you want to clarify, please do so. And in the meantime, while we wait for that, if we have any other questions, if there are any other questions or anybody else wants to speak, you can please indicate. Paul, I can see you, but you're still muted. So if you can unmute.
Hello.
Yes, we can hear you.
Oh, okay, thank you, Ashia. Thank you for bringing up the question, but I was actually directing the question to the guy from Sokoto.
Okay.
It's not to Dr. Detiba. The guy
All
that
right.
was giving us best on how they were able to meet up with the percentage shared by Dr. Detiba. So I was asking because in his presentation, he said that when samples are locked, when the samples are brought to the lab, he used to stay 2 to 3 days before results comes out. And following the guideline, national guideline, we know that if you are looking at turnaround time, it should be within 4 hours for results to come out. So taking it more than 2 days is actually not acceptable. And if that is the practice, then that's what I wanted to address in this call. Thank you.
Okay. All right, thank you. Unfortunately, Aliu, I think, has dropped off because I cannot see him on the list any longer. And I think his network was not great.
So the question is left unanswered.
The question is left hanging, unfortunately, because he's not here to respond to it. But I mean, we can facilitate asking him that even beyond the call and getting a response for you from there. But it looks like we've run out of questions. I don't know if there's any.
Sorry,
yes.
Hello. There's a question from Vincent Morens.
We've answered it.
Okay, we have,
Yeah.
Okay.
Been responded to. Yeah.
Okay.
I think we've basically gone over all the questions, and I can't see any new questions, which is perfect timing because we have 1 minute to the end of this webinar time. So I just want to thank you all. I want to thank, first of all, the presenters, every panelist. Thank you so much for having such a very interesting and engaging presentation. I don't feel like we've even really been able to really break down everything that was spoken about here. So I'm glad that we have the presentations that we're going to share. So please continue to engage with that. Each panelist is extremely busy, to be honest, to find time, to find 2 hours to sit down and just basically talk about the work that we've been doing and so on and so forth is not easy at all. Right now, Dr. Obioma is in transit somewhere in the world. Dr. Adetiba is in transit. Dr. Sheshi is very busy. Stella is very busy, so that we can that they still took the time to spend 2 hours, even before that, preparing a presentation and coming here to engage with all us is a real privilege. So thank you for sharing your experience. Thank you for taking the time to discuss this with us. For all the attendees, thank you so much. We had a lot of engagement. Right now I'm seeing 126 attendees, but that's just now. At the beginning, it actually started out at 140 something. So I thank you all for joining. Please continue to engage with us, continue to share your questions, continue to reach out. All the presentations that were made here are going to be shared with all of you. And please feel free to continue to join us. We want to be doing these kinds of webinars at least on a quarterly basis on relevant topics. So if you have any topic or any feedback you want to share with us, we're open to hearing. As I mentioned earlier, if you have not are not part of the network, please join the network. And yeah, so that's really all from me. Thank you so much for joining, and I look forward to engaging with you the next time we have this webinar. So I'll give it up to Stella to basically end it formally, and then we can go.
Yeah, thank you very much, Aji. So I want to appreciate all that has been on this call to this time. It's really not easy, 2 solid hours, and I want to believe that we have all, the webinar have, our expectations have been met by this webinar. So we still have, you can still call on us, NTBLCP, to shed more light where you think is still, gray areas. So please feel free to do that. So there are some takeaways for us and maybe next steps, if I would put it like that. So we have from Dr. Obioma's presentation, we know that training, that is what it is. But what we bring to it, that's the innovation we put into it, will be what will make the difference. So we can't do without training. So for us, we have the training materials, which is given at different languages. We have enough time, to do demonstrations at that facility level where we are doing the training. Then training materials are modified to fit, the staff or the cadres of staff that are being trained. Then some innovations like training of a group of staff at a time, instead of, when you go to a facility, you train one person, we need to train more, not just 2, 3, or 4, but more if they are available anyway. So that in case of staff attrition, we can always have somebody that will replace. Then having regional or, master trainers, pool trainers is really something that is innovative, that is upcoming. Then many PPM mapping of PPM centers, to classify them based on the schemes they offer. Now, looking at Dr. Adetiba's presentation, in fact, our major takeaway there is, our major takeaway there is that in GC7, we have this mentor-mentee coming up, mentor-mentee program, which is like bringing together mentors, pull up staff as well, just like Dr. Obioma said. Then development of these digital training platforms at self-paced, is done is virtually, done. Then TB/HIV integration, will also help us to offer holistic care. Then for the care CV, our major takeaway there is the competency training, which is a web-based training, and self-paced training. So people get trained for specific activities. So and after the training, if they are assessed, and those that need that have further needs, they are mentored, one-on-one. So, and all that training is free if you need them. So that is where we'll cap it today. Of course, the diagnostic, that is Mr. Emmanuel also made it also appeal that we should keep training, and not just when you come to a facility, you train one person. No, we should train more people. Then Aliu also made it clear that there is that insecurity challenge in Sokoto State. So people in the rural areas find it, difficult to come out to access public and private health TB services in the state. So I want to appreciate everyone for all our time. So thank you, and God bless you.
Thank you, everyone.
Yeah, thank you.
Bye. See you next time.
Bye.